Okay, well, it's a pleasure to be here to present on this topic, and I really do thank the organizers, sort of. So anyway, let me figure it. Okay, so March 23rd, 2010 is when the Patient Protection and Affordable Care Act became federal law. And for the rest of the talk, I'm going to refer to it as either the ACA or the Affordable Care Act. This actually really did initiate some of the most significant changes in healthcare in the United States in over 50 years. Medicare was established in 1965. The Social Security Act was 1935. And this has really been a major agenda item for our government and for the United States as early as 1912, when Teddy Roosevelt, with the Progressive Party platform, proposed some type of social insurance to keep poor people from falling through the net. It's to provide a safety net. Why do we need this? We need this for a couple of different reasons. There are three big areas in which medical care, in terms of the way that we provide it, the way that we look at it in terms of patients in this country, and these include access to care, the cost of care, and the quality of care. In the US, there really are huge problems with the cost of medical care. In 2010, we spent $2.6 trillion. This represented about 17% of the gross domestic product. And it is calculated that if you look at a trajectory, that in 2080, this will be 48% of the gross domestic product, which is unsustainable. The second is access. It's actually closer to about 4.8 million people were uninsured in 2012. And a large part of the quality of our care has to do with the fact that patients aren't getting the care. It's not what we provide, but they can't get that care. And finally, the quality issue. We spend the most in per capita dollars on healthcare in the world. We rank last among 11 industrialized countries in the healthcare system quality, efficiency, access, equity, and what are calculated as healthy lives. And those flags on the side show you the ranking of the 11 countries, with Great Britain at the top, and we're down to number 11. It's actually interesting. We are the only industrialized country that doesn't guarantee uniform access of all the lives in our country to care, and we're the only country that looks at healthcare as clients or consumers rather than a sick person. I like to look at my patients as being sick people, but our country and our healthcare system look at the patients as consumers. So what is the Affordable Care Act? What we hear about the Affordable Care Act is really what we hear from the media, what we hear from the politicians. And if any of you live in North Carolina, what we heard from our very tight Senate race. We heard a lot about the Affordable Care Act and how we were cutting off insurance from everybody, and we were having death panels and killing Granny. And it's not the case for killing Granny. It's change, and that pile of papers there are the 935 pages of the Affordable Care Act. The Affordable Care Act is more than just insurance. I'm going to concentrate on some of the insurance aspects today because these are things that our patients are coming to us. These are the things that are going to directly impact their access to our healthcare system. But it's actually 10 different titles, of which quality, affordable healthcare for all Americans is only one part of it. You'll be hearing a little bit later about some quality. That is a component of the ACA, and also transparency and program integrity, where consumers, patients, should be able to tell in different institutions what the costs are going to be, what the quality rates are going to be. So that is all part of the ACA. But if we look at the insurance component, many of our patients are really not going to be able to tell a difference. pre-ACA and post-ACA. These are how patients are actually insured. The large purple, the bulk of the patients are getting their insurance through their employer. And other than a few tweaks in the insurance, those patients are really not going to see huge, vastly different changes. If you look at the light blue area, that is the uninsured population, and that is about 1 in 5 patients. The orange area are the Medicare patients, and the purple area, the more purple area, are the Medicaid patients. So those are the publicly supported insurance programs, but we still have this huge bulk of patients that prior to the ACA really didn't have access to insurance. And a lot of these patients are really the working poor. They're patients who are working, their employers do not give insurance, but they have too much money to qualify for any kind of subsidy. Just to remind you right now, because we'll be looking at this in a few minutes, the federal poverty level for a single person is in the range of $11,500, and if you take a family of 4, the federal poverty limit is an annual salary of $23,000. All right, so how does this play out for our patients? The ACA is attempting to address some of these issues. The large part of the ACA in the insurance category is actually trying to reform the non-group insurance, so the non-employer insurance. If a patient is insured, children can remain on parents' plan until the age of 26. Companies can no longer drop coverage if the patient becomes sick. In the past, insurance companies, if a patient was becoming too costly, they could get rid of that patient from their insurance rolls. There's also not a lifetime limit on coverage, which is exceedingly important for our patient population, especially as they get into some of the more expensive drug needs or multiple surgeries. There's no cutoff that would then lead to catastrophic financial issues. Insurers are barred from using the patient's health history to set rates. In the past, if a person was deemed to be fairly expensive, if they had IBD, if they had diabetes, their rates that they're paying for their insurance might be higher. And this is very evident if any of your patients have a gap in insurance and they're going through COBRA, those rates can be very, very high for patients that are medically costly. And there are certain preventive services that have to be covered now. One concept that we will see through the ACA are essentially what is considered shared costs. Basically, what shared costs are copays, the things that the patient must pay in addition to what the insurance company pays. And so for the preventative services that we'll be looking at, there's no shared cost. The patient doesn't have to pay anything. If a patient is insured with Medicare, by 2020, the law will close the donut hole, which again, for our IBD patients is very, very important because for some of our more expensive drugs, there may be a period of time where their drugs are not covered. Certain preventive services, again, are going to be covered without that patient cost savings. If the patient is uninsured and does not meet exemption requirements, for example, if they are in the military or they're a prisoner, they're exempt from, they get insurance in different ways. So if they're uninsured and do not meet exemption requirements, they may be covered by expansion in the state's Medicaid program. North Carolina is not one of those states. Or they will need to purchase health insurance from another source. I put down through the health insurance marketplace, and we'll be talking about the health insurance marketplace, but there are other potentially private forms of insurance that they could attain as well. So if the patients, again, are uninsured and they're purchasing through the health insurance marketplaces. The marketplaces are actually made up of private insurers that offer multiple plans. Consumers can compare these plans and see if they're eligible for subsidies to help cover the costs. The federal government provides a certain amount of subsidies, up to 400% of the federal poverty level, to help pay the monthly premium. And again, the key thing is that there are different degrees of cost sharing on the available plans. And I'll explain what that means. So, just to review, typically Medicaid is limited to certain low-income populations, so basically handicapped, disabled population, children, and pregnant women. So you can be below the 100% federal poverty level and not be eligible for Medicaid. The expansion program to the states basically extended Medicaid coverage to individuals who were below 138% of the federal poverty level. So these are patients that are well, these are patients that are sick. As long as they are below 138, the states had the opportunity to expand Medicaid to provide coverage to that group of patients or people. And this just gives you, find your state there. A large part of the country did not expand Medicaid, and the orange are the people that did not, the blue are people that did, and the light blue are the areas that at the time that this slide was made were open to debate. So if you're in the dark blue, your state may be in a little bit better shape. So the health insurance marketplaces, I can honestly, the first patient that I had that started telling me about her health insurance marketplace, I had no clue as to what she was talking about. These have been created for those who need to buy their own insurance. It's done state by state. Some of them are state-run, like California. Some of them are federal government facilitation. Some of them are a state-federal partnership. They offer a range of plans, different coverage options, and we'll look at those individually with the coverage options. The key thing here is that the plans may have different network providers, so that becomes very important for a patient selecting a plan. The other concept here that may actually go away, who knows with the next Congress, is the individual mandate. When they talk about the individual mandate, what is being spoken about is the requirement that all patients have some type of insurance, and there will be penalties that in several, like the first year are very nominal, $96 a year if you don't get insurance. In a couple of years, those penalties may be up as high as $2,000 a year without insurance. So individual mandate, something to keep in mind. So again, these are the marketplaces, state, federal, and combination in the different areas. And the gray is the state, federal, combination states. So who can use these healthcare marketplaces? You have to be a U.S. citizen. You cannot be a prisoner. And you have to live in the United States. So if you don't have employer insurance and you are overseas and living overseas, you can't use the healthcare marketplaces. They're used in the United States. So just to give you an example, these are two of my clinic patients. The first one is CS. I've been taking care of her for probably over 20 years. She had Crohn's disease since age 10. She's now 50. She was unable to get affordable insurance due to a pre-existing condition. She was turned down everywhere. Then she had to go part-time. She's a social worker. She had to go part-time due to her health issues, and for 10 years she had no health insurance. So basically avoided medicines, avoided any kind of care, borrowed prednisone. And she came in right after the ACA was passed. She was reestablishing care with me and a primary care doctor, and she said to me, ACA was meant for someone like me. because she could pay her premium, she could get her health insurance. The second patient is a young woman who's had ulcerative colitis since age 14. She's now 24. Her UC was in a prolonged remission. She got a job as a prison nurse and quit due to the stress of the job. She then got ACA marketplace coverage and then had an ulcerative colitis flare. And she was the person that kind of stimulated me, look at this, because she says to me, I thought the silver plan would work, but I can't afford my medicines. And I'm sitting there going, silver plan? What the heck is a silver plan? So the plans. There is catastrophic health insurance available for patients under the age of 30, and that's not included in these plans here. The lowest premiums plans are the bronze plan, and the highest premium plan is the platinum plan. And the highest out-of-pocket costs are in the bronze plan, and the lowest out-of-pocket costs are in the platinum plan. To give you an example, if you were 34 years old living in North Carolina, your premiums would range anywhere from mid $200 per month to $300 per month. If you're my age in North Carolina, you'd be paying between $400 and $700 a month. This just gives you an example. You can look at this later, and it just shows you the difference between the plans. The key thing here is you have your monthly premium, and then you have an out-of-pocket maximum. So last year, the out-of-pocket maximum for your deductibles for the visits you pay is in the range of $6,300. So you can imagine if you have an income of $10,000 and you are ill, that will be taking up quite a bit of your money in terms of that. If you want to figure this out for a patient, the Kaiser Family Foundation actually has a very, very nice website. They have published a lot on the Affordable Care Act, and there is a calculator that will calculate what the subsidies are. So if you are poor and you are in the range of $15,000 a year, $15,000 a year, and you're at about 133% of the federal poverty level, you will get a tax credit of about $2,000, so your amount that you're paying per year is only $303 through the healthcare exchange. So between 100 and 400% of the federal poverty level, there are subsidies by the government. So what do the patients need to ask? What questions do they need to ask? What do you need to counsel them? The first thing is the patients need to look at the different plans, and in North Carolina, there are about 10 different plans patients can choose between. If patients are on higher cost drugs, they really need to be on the gold or the platinum plans. But they also need to look at the drug formulary. They need to know whether their drugs are covered by that plan. They also need to know whether you are in their network of doctors, and if you are not, is there somebody who can take care of them who is covered by the plan? And then, are there other financial resources available in the state? There are a number of patient advocacy groups and patient assistance programs that will help with the medications. The Leukemia and Lymphoma Society actually has thought this out very, very well, probably better right now than the IBD community. And they have, the information is in your packet, but they have some very nice information for patients on their website. But this gives you an example of, in different states, what the specialty drug cost would be. So if you're in Massachusetts and you're on the silver plan, you pay $210 for your specialty drug, and if you're on the bronze plan, you have to pay 50% of that drug. If you are in New York and you're in the silver bronze plan, you're only going to be paying $70 for those specialty drugs. If you're in Connecticut, whether you're on silver or bronze, you're going to be paying about 50%, which can be quite costly when we're talking about some of our biologics. All right, the essential health benefits. Basically, emergency services, laboratory services, pediatric services, wellness services are all covered, and mental health services. What we need to know for the preventive services where there are no co-insurance, no co-pays that we would see. Colorectal cancer screening for adults over the age of 50 is considered a preventative service. So the patient should have no out-of-pocket cost for that. That does not include surveillance for ulcerative colitis because it's no longer screening, it's a surveillance exam. We also, immunizations are covered, tobacco screening, those are all things that we can incorporate in our plan. So, are ambulances covered by insurance on the ACA? Yes, if an emergency, that's to a hospital or between hospitals. No, if not an emergency. I don't know why anybody would be paying for their ambulance to the morgue, but that was included. So are dental services covered? Not for adults, they are for kids, but some marketplace plans do include dental insurance for a fee. Are ostomy supplies covered? Yes, as well as multiple other durable goods, which this is really advantageous to a number of our patients with ostomies because it tends to be a rather large cost. All right. So I'm going to end there, and this is just in an overview, in a nutshell. Again, the Kaiser Family Foundation has some very good resources, and there's some outstanding YouTube videos that I used to understand this a little bit more that are designed for patients both in English and Spanish. And coverage ends, the enrollment ends for January 1st on December 15th. By February 15th if you want to get coverage in 2015. And thank you.
Thanks, Kim.